Bismillahirrahmanirrahim. So now we are going to discuss about hypernatremia. That means that the sodium levels are rising inside the blood, okay? And the normal sodium level is from 135 to 145 milliequivalents per liter. It's milliequivalents per liter. But in case of hypernatremia, the sodium levels are more than 158 milliequivalents per liter. That's obvious hypernatremia, right? In case of hyponatremia, when the sodium levels were very low, we were using a hypertonic saline, that is 3% saline, and this saline contains a large amount of sodium and chloride, and that's exactly we need to treat hyponatremia component. But in case of hypernatremia, when the sodium levels are already increased, we are using hypotonic saline, that is normal by 2. What does it mean normal by 2? The normal saline is 0.9%, and we divide it by 2, we obtain a number that is 0.45% saline. Whether we are using the hypotonic saline or we are using the next option is 5% dextrose. It's 5% dextrose, okay, it's sugar. So the fluid of choice in case of hypernatremia, it is fluid of choice in case of hypernatremia is either 0.45% saline or it's 5% dextrose. Either of them can lower the sodium levels to the moderate amount, right? So what is the etiology behind hypernatremia? Let's discuss about etiology. Etiology depends on various conditions, like for example, the first is the geriatric age group. What does it mean? Geriatric. Geriatric age group means the persons who are in their 80s or 90s or 70s, right? They have old age, geriatric age group, or the patient of the geriatric age group is having extreme debilitation. Extreme debilitation. The person cannot either walk, or he cannot talk properly, or he cannot ask for water, or he might have a hip surgery. Okay, hip surgery. Why I'm mentioning these odd conditions? It's because that these all conditions leads to water deprivation. And the next thing from the geriatric age is the Alzheimer's disease. In case of Alzheimer's disease, the patient's memory is lost and the patient cannot either walk properly, or he cannot talk properly, or he have extreme debilitation. So they cannot ask for water, okay? There will be water deprivation in these patients. Water deprivation in these patients. Water deprivation, or we can say water depletion deprivation. So these patients do not ask for water, and inside their blood the water is less and there is concentrated amount of sodium, that is hypernatremia. The second condition is that if a person is suffering from diabetes insipidus. What does mean diabetes insipidus? In which the antidiuretic hormone is very low. Either it can be due to nephrogenic cause, or it can be due to central cause. The nephrogenic means that the ADH is not being produced from the posterior pituitary, or the central means that kidneys V2 receptors are irresponsive to the ADH hormone. So diabetes insipidus, in either of the case, these patients will have polyuria because water is being lost in these conditions. There is polydipsia, polyuria, polydipsia, and the urine osmolality will be low because a huge amount of water is released, right. So urine osmolality will be low. It is reduced to less than less than 250 milliosmoles. Although the urine osmolality fluctuates between 100 to 900, but in this condition of diabetes insipidus, their urine osmolality is reduced so much, right? 250, less than 250. And in this condition, these patients, in spite of polydipsia, they are not drinking water. They are not drinking water, okay? That's the condition of diabetes insipidus. And I've told you there are two types. It can be central due to trauma, brain abscess, due to meningitis. The central means that the antidiuretic hormone is basically not being produced, and the nephrogenic. Nephrogenic means that the kidneys are irresponsive to the antidiuretic hormone. So, until up till now, we have learned that either there is water passing into the urine or it can be not getting enough water. So, these conditions can lead to concentration of blood and there will be hypernatremia component. The third condition is sweating. Okay, it can be a sweating because the sweat contains salt along with a huge amount of water. The water is lost from the body again in the sweating, and in this condition when the urine will become concentrated in condition of sweating, the urine osmolality will rise. It will rise because due to a passage of large amount of water across the sweat, the urine osmolality automatically rises because there is not enough water inside the body. The fourth condition, it can be lactulose toxicity. Lactulose toxicity, when a person ingests a large amount of lactulose. What is lactulose? Lactulose is a laxative. It is laxative. Basically, it's osmotic laxative. What does it mean? It means that it's gonna treat the constipation. It's gonna treat constipation. So if a person is suffering from constipation and the doctor prescribed him or her lactulose, the lactulose will cause osmotic diarrhea. The most common side effect of lactulose is osmotic diarrhea, and diarrhea means that there are loose motions, and along with the stools the water is going to be passed, and again the person will be water deprived. And the fifth condition is similar to lactulose. It is mannitol toxicity. What is mannitol? Mannitol, like osmotic laxative, the mannitol is osmotic diuretic. Osmotic diuretic. Diuretic. It will help to control swelling inside the body. When there is a lot of edema component occurring inside the patient's body, it's used to treat edema or swelling. It will cause excess amount of water. That water that is extra, it will cause that water loss from the body, water loss. Okay, mannitol. So in all these conditions, the person is either not drinking the water or he is suffering from water loss, either through the GI route. It can be due to sweating, it can be due to urine, it can be due to vomiting as well. So the last condition which can contribute to the development of hypernatremia, it is post-operative patients, because post-operative patients are under a large amount of anesthesia. They are under IV fluids. They are not drinking appropriate amount of water. The water content of such patient is reduced because they cannot ask either, or they are very lazy, or some other factors come in and they do not drink water. So they can contribute also to the development of hypernatremia. One of the types of hypernatremia, it's asymptomatic asymptomatic type of hypernatremia. It means that the body's sodium is rising, but it's not rising to the level that it may lead to seizures or convulsions. No, it's asymptomatic, right? So the treatment for the asymptomatic hypernatremia, it's the liberal water intake. The doctor prescribed to drink a large amount of water. Liberal water intake is enough to treat the asymptomatic hypernatremia. But when the symptoms kick in, we have to do some other treatmental procedures, right? So what is the fluid correction of hypernatremia? We will going to discuss that volume of the fluid correction. What is the formula? The volume of fluid correction. We will also discuss an example. Just for now, we are discussing volume of the fluid correction. Like the hyponatremia, there is also a formula in case of hypernatremia. It's total body water. The actual sodium, the sodium actual that the patient is having currently, sodium actual minus 140, and we'll divide this whole term by 140. That's easy to remember, right? Total body water, sodium actual minus 140 by 140. Let's take an example of a female athlete, because in case of female we multiply it of the total body water. How to calculate it? First of all, in case of females, we multiply the weight of the female multiply by 0.5, and in case of males we multiply weight by 0.6. So we have taken the example of female because it's convenient. We just multiply it by 0.5. So for example, if a female of 60 kgs is suffering from hypernatremia, and when there is electrolyte panel set in, the electrolyte of the sodium came out to be 160, and it's very large, right? So let's calculate the volume of the fluid correction that must be given over 24 hours to the patient in order to correct the hypernatremia. Total body weight, total body water, how we'll calculate it? 60, because weight is 60 multiplied by zero point 0.5. What is the sodium actual? It's 160. We minus it by 140 and we divide the whole term by 140, and a little bit of mathematics, and the answer is approximately 4 liters of fluid. And this 4 liter of fluid to correct the hypernatremia component must be given over 24 hours via infusion pump. Via infusion pump. This amount of fluid is not given very abruptly or very fastly, because again, like in hyponatremia, the fast correction can result in edema, and it can lead to like cerebral pontine myelinosis or osmotic demyelination syndrome that is very dangerous. In case of hypernatremia, the same condition occurs. Only per 24 hour we can only decrease by 8 milli equivalents, okay, per 24 hours we cannot decrease more than 8 milli equivalents in case of hypernatremia as well, and in case of hyponatremia we can only increase by 8 milli equivalents per day per 24 hours. So that's the thing we need to remember, although it's just not being asked in the exams, but it is worth mentioning about the um, application of the formula. So that was for today, and in the next lecture we'll discuss about hypokalemia and its etiology, its management, and the symptoms. I will see you in the next video. Till then, goodbye.